Alright, so this is the last lecture on carbohydrate metabolism for Unit 3, and in this lecture we're going to quickly go through the metabolism of fructose and galactose and some relevant clinical pearls. So first, fructose metabolism. Fructose is present in fruits and vegetables as a free monosaccharide, and then it can also be formed from the disaccharide sucrose on hydrolysis. So down here you have the sucrose, and remember in the GI tract, you have these enzymes on the epithelial border that can hydrolyze these disaccharides into their individual monosaccharides that can then be individually absorbed. And so that's another source of fructose. The majority of fructose metabolism occurs in the liver, and then fructose is sometimes given to diabetics as a source of carbohydrate that does not require insulin. So briefly, the steps of fructose metabolism. It's very similar to glucose metabolism. So you start here with fructose, it enters the cell, and then it's immediately phosphorylated by an enzyme called fructokinase. And it uses a phosphate group from ATP, and it adds it onto that one position to give you fructose 1-phosphate. This is analogous to glucokinase or hexokinase, which phosphorylates glucose into glucose 6-phosphate. And remember, the purpose of that phosphate group is to trap fructose within the cell so that it cannot leave. And then fructose 1-phosphate is split into glyceraldehyde and dihydroxyacetone phosphate by the enzyme aldolase B. Then glyceraldehyde and dihydroxyacetone phosphate can then be converted into glyceraldehyde 3-phosphate, which can be used in glycolysis. These two intermediates can also be used in gluconeogenesis for glucose synthesis as well. And then glyceraldehyde can actually be converted into glycerol as well. So the bottom line is that fructose metabolism, very similar to glucose metabolism, and the end result is that you end up creating intermediates that can then enter into glycolysis. So the first disease we'll talk about is fructosuria, which is where you have defective fructokinase enzyme. And this is an enzyme mainly found in the liver, and this is this first step here in fructose metabolism. So you're not phosphorylating fructose to fructose 1-phosphate. The inheritance is autosomal recessive, and really this is a relatively benign condition because really what happens is since you can't phosphorylate fructose and trap it in the cell, you end up just peeing it out usually. Or by other mechanisms, it can get converted to fructose 6-phosphate and then be used in metabolic processes in the cell. But again, it doesn't build up and cause any kind of toxic effects to the cells or tissues. And so it's a very benign condition. However, fructose intolerance is not a benign condition, and this involves deficiency in aldolase B, which is actually the rate-limiting enzyme of fructose metabolism. So this is that second step here that's converting fructose 1-phosphate into glyceraldehyde and dihydroxyacetone phosphate. So this is missing. You have decreased amounts of these, and then you have a buildup of fructose 1-phosphate, which is a problem because fructose 1-phosphate is toxic, and so it causes damage to hepatocytes. And then as a result of that, gluconeogenesis and glycogenolysis cannot take place in the liver. This is a downstream effect of the inability to convert this to glyceraldehyde and dihydroxyacetone phosphate, and the fact that this is toxic to the cell. So remember, this phosphate group that's added helps trap fructose in the cell, and so the problem is if you have a buildup of this, fructose 1-phosphate is trapped in cells. This results in a decrease in ATP production, because remember, you used up ATP to phosphorylate fructose to convert it into fructose 1-phosphate. So some of the testing that's done for infants or babies that would present with this is a urine dipstick, but that's actually going to be negative because it only tests for glucose in the urine. The urine, however, will be positive for a reducing sugar such as fructose. Clinical features: since this mainly affects the liver, it's going to cause liver damage, lead to cirrhosis, which can cause jaundice. And then also, since it affects gluconeogenesis and glycogen breakdown of the liver, you're going to have fasting hypoglycemia because you're not able to produce glucose during the fasting state. You could also see hypophosphatemia and then vomiting as well. This disease can eventually lead to renal dysfunction. And the big thing here is then what you want to be looking for in a question stem is that these symptoms come after ingestion of juices or sugary type foods such as fruit. So an example could be an infant has been bottle fed with normal formula or breast milk, and then one day the mother gives the patient something such as applesauce, which contains a lot of fructose, and that triggers the symptoms, and you see these symptoms as a result. And so that's going to tip you off to a fructose metabolism disorder. All right, so galactose metabolism. Galactose is consumed primarily as lactose, which, as you probably know, is found in dairy. And then lactose is hydrolyzed in the GI tract into glucose and galactose respectively. So just like we said with sucrose, in the GI tract, you have the lactase enzyme, which hydrolyzes this bond and splits these into two monosaccharides that can then be individually absorbed in the GI tract. And then galactose metabolism, like fructose metabolism, primarily occurs in the liver. So the steps of galactose metabolism. So just like glucose and fructose, when galactose enters the cell, it gets phosphorylated using an ATP, and it gets phosphorylated by the enzyme galactokinase. And then that converts galactose into galactose 1-phosphate. So you have a phosphate on that one position. Then you take the uridine monophosphate group of UDP glucose, found here, and transfer it to galactose 1-phosphate via the enzyme uridyl transferase. And that forms glucose 1-phosphate. So you're essentially converting galactose 1-phosphate into glucose 1-phosphate. And in the process, that yields a UDP galactose. And this UDP galactose gets converted back to UDP glucose by the enzyme 4-aperamase. So now that we've covered galactose metabolism, let's talk about the two disorders that you're going to most frequently encounter on exams for galactose metabolism. So the first is galactokinase deficiency. Now, these two disorders, they can be generalized as galactoseemia, and we don't like to refer to them as, I think that's too broad of a term, so you want to be using galactokinase deficiency, and then you'll see next classic galactoseemia. So galactokinase deficiency, it's in the name, it's a deficiency of the galactokinase enzyme. Inheritance is autosomal recessive, and so really what you're missing here is that first step here, where you're phosphorylating galactose to galactose 1-phosphate. So as a result, you're going to have a buildup of galactose. And these symptoms start very early in age, at the infant stage, really, when a baby is given breast milk or formula, because those both contain galactose or lactose, which is broken into glucose and galactose. And one thing I'll point out is that this is actually a relatively benign condition, especially compared to the next disease we'll talk about, classic galactoseemia. So just some clinical features of galactokinase deficiency. So you're obviously going to have galactoseemia, high levels of galactose in the blood, galactoseuria, high levels in the urine, and then you're going to develop cataracts. And the way you develop cataracts is, so this is lost, you have an increase of galactose, and then galactose can get converted into galactitol, which is actually very toxic for the eyes and for neural tissue. So you have a buildup of galactitol, and so what this ends up happening is that galactitol accumulates in the lens of the eye. And so it accumulates in the lens of the eye, and that causes an osmotic force to drive water into the lens and causes it to swell, and that leads to cataracts. The other thing is, since galactitol is damaging to neural tissue, you could have developmental delay for milestones. Two examples of this that you could see in a question stem are failure to track objects, or inability to develop a social smile. So in response to human interaction. The way you treat this is really you just got to avoid lactose and galactose in the diet. So you need to switch them to a special type of formula that doesn't contain those. And then the thing is that most states have mandatory screening in newborns, because the earlier that this disorder is caught and that you change the diet, the less likely they are to suffer long-term consequences of this disorder. Now, classic galactoseemia, this is the complete absence of galactose 1-phosphate uridyl transferase, which is the rate-limiting enzyme for galactose metabolism. So you're missing this here, so you don't get production of glucose 1-phosphate from galactose 1-phosphate. That leads to a buildup of galactose 1-phosphate within the liver, and then you also have a buildup of galactose, which then leads to a buildup of galactitol, which is obviously toxic. The inheritance is autosomal recessive, and like we said, it results in an accumulation of galactitol, which is toxic to the lens of the eye and neural tissue. And this buildup of galactitol is actually more severe in classic galactoseemia compared to simple galactokinase deficiency. So the clinical features of classic galactoseemia are galactoseuria and then hypoglycemia. And then since that galactitol causes such damage to the neural tissue, you're going to have retardation, hypotonia, and growth delay. And then since you have buildup of galactose 1-phosphate, galactose, and then galactitol in the liver, you're going to have hepatomegalia, with cirrhosis, and jaundice. You'll also have cataracts. We've already explained how that happens. And then these patients also exhibit vomiting and diarrhea. A unique thing for classic galactosemia is that it can cause E. coli sepsis in neonates. So you definitely want to be paying attention to that if you see that in a stem. Treatment, same thing here. You got to avoid lactose and galactose in the diet. And again, most states have mandatory screening for this in newborns because the sooner you can catch this and change their diet, the better the long-term outcome. So we've added this last slide here to help tie together some concepts we've said about both diseases and to help you really distinguish both of them when you encounter them on an exam. So both diseases, the symptoms are going to present very early when an infant begins feeding. And again, that's because lactose is present in breast milk and in routine formula. Galactose is going to appear in the blood, galactoseemia, and then also going to appear in the urine, galactoseuria. Both disorders are going to have infantile cataracts, and again, this is due to the buildup of galactose, which is then getting converted to galactitol, which is toxic to the lens of the eye. Galactokinase specifically, remember, is the milder form, or the milder disease between the two, and it's going to have cataracts, and it may also present with some of those developmental delays, such as failure to track objects or develop a social smile. Classic galactosemia is going to be worse, and these patients are going to develop with failure to thrive, jaundice, hepatomegaly, and then intellectual disability. And something unique about classic galactosemia, again, it can lead to E. coli sepsis in neonates. All right, so that closes out our discussion of fructose metabolism and galactose metabolism. And it also closes out our lecture series on carbohydrate metabolism. Next, we're going to start talking about fatty acid metabolism.